Hello again. It's very nice to be here with you. I appreciate the opportunity to virtually visit and learn how the Minneapolis inner city marketplace expanded the American Indian healthcare access and improved diabetes health outcomes. The title of Marketplace Clinics Complementing Diabetes Care for Urban Residing American Indians, and presented this afternoon to our Nursing Congress Spring 2021 conference. My name is Robert Rick, and we'll move on. We'll keep going. So, as applied research, we compared the diabetes health outcomes. I should say applied research is really important. I think of getting into a project like this, I think I devoted at least 3 years and served as this person here, along with to learn more about diabetes and help out as best I could with making progress for other diabetics. Our education and support so that we could avoid being victims of diabetes. The project itself was a controlled. We can look at the controlled study, case control, and had 3 years data. The size were 135 participants, and we used our study and this research to test whether the marketplace clinics and the cross-cultural study group, a partnership of diabetics, or APOD, had improved their diabetes health outcomes. And the A1C, the BMI, or body mass, and blood pressure compared to the Urban Indian Health Organization, UIHO. We evaluate this extent that the marketplace clinics, CVS, Walmart, Target, Supervalu stores expanded their healthcare and effectively complemented the community-based diabetes support group. In the inner city Minneapolis, largely cross-cultural urban Indian, and we can see in the shaded green areas of this map, which denotes medically underserved people, populations. We break it down a little bit more. If anyone's is an urban area, perhaps not unlike some other advanced cities, big cities throughout the world. But in this case, we had our APOD group centered within the medically underserved area. We see the large red dots. These denote affluent census tracts, rather large. The green dots we see show the medically underserved census tracts, larger and smaller populations, people in those areas. The blue S, little radio buttons, show the supermarkets. such as in these marketplaces. We show here, for example, the supermarket being large Target stores located here along Lake Street, and 2 or 3 in the eastern and western area. Along Franklin Avenue, and the Lake Street locations also include the food marketplaces, Supervalu stores. I think there are some other names for them, but they also have the clinics, different on-site retail clinics within their location. We can see the project plan, again, to see in a pre-planning way. We wanted to talk and get buy-in again, and look at this complementary care criteria to see whether the reciprocating marketplace clinics, and as you look at, have some ideas about how this concept might work in your particular locations. You'll find out, really think about whether these clinics can meaningfully contribute to the community-based support group. So in just going in, and during the 4 years course of this study, financial management and management support was provided, and the marketplace contributions, contributors really, as we talk with them in advance, refined their cost quality strategies. They looked at whether they were more socially responsible, and to be able to deal with some of the problems to be encountered, and certainly we found that there were some limitations. Different people would have different allegiances to different cross-cultural groups. American Indians had their corners of the world, and as did non-native people. Data collection and analysis was a bit of a hurdle. Being able to deal with the arguments about a person's Indian blood quantum, or what percent of American Indian ancestry different urban Indian people had, and how that would be viewed by the rest of the group, and particularly by dealing again with some of the marketplace leaders. We began to focus more on how this quality of cultural awareness was theirs to be able to engage and reach out to the medical underserved and American Indian people, to be able to actuate self-efficacy, see whether this self-care philosophy and implement the complementary network, whether we could expect much help from the marketplace. And indeed, we did receive very extraordinary public-private leadership, dedication, and long-term commitment that really stepped up to the place. The significance of this research project is that it accepts the urban Indian health disparity challenge and commits research towards urban health Indian improvement. We will recognize here that this study could not have been completed without the kind of communicative interaction with the Minneapolis community, the city, the University of Minnesota, and the Little Earth of United Tribes. We see here that the primary care and community health combinations can be realized by triangulating the marketplace support for cross-cultural, medically underserved indigenous populations. I should have referenced Dr. Clayton Christensen earlier as being the kind of the innovator for the concept of the marketplace clinics and that innovation, and perhaps the difficulties with the disruptive intervention. It's talked about a lot. We'll have his reference later that you can take down and check out if you haven't already done so. So we'll also note that physicians from Mayo Clinic, who are now in practices throughout the Minneapolis area, had a great deal to do with coming up with their this concept of blending the marketplace support, the community, the patient activation concepts, primarily driven by the nursing community, and then diabetes care, this marketplace triple aim. Quantitative looked at the extent to which marketplace complemented the APOD study group and how well they managed their diabetes trends, A1C, BMI, body mass, and blood pressures more effectively than the urban Indian control group. For the two groups, the effect size was determined by, and we had two different groups. I think for an article for publication and perhaps for approval from the editors and so on, it's the best to have two different statistical looks at this. We used the Cohen's D, which is a measure, and also the hypothesis testing was done by using t-tests. Patient activation measure, the PAM, which is Dr. Hibbard's invention, was used to look at whether people's behaviors and their health care was actually improving or not along a 5-point Likert type scale. And then again, PAM scores, which we'll look at in a moment, how that works along for motivational interviewing. The first focus in this study was participants and the effect of a marketplace complemented diabetes support group, APOD, which was the independent variable, on patient activation and the attendant clinical outcomes, the dependent variables. We used SPSS, statistical package for social sciences, and we to actually measure any statistical difference. Here is a copy of which is available to you. It is trademarked. It's published in the referred to article that I co-authored. It's a note that it is a copyright, and we have the link to the Insignia Health. We'd encourage you, if use it, that's fine. Refer to it, that's fine. For nonprofit and non-commercial use, but it is copyright, and you might want to check with this link for Insignia Health, and you might get a chance to talk with Dr. Hibbard also in that regard. You just can't underscore how kind and gracious she was throughout our project. We have here a look at the APOD group cases. We had the number, I had 48 participants. The frequency distribution, or I guess a bar chart, shows this as being a mean of a little under 7, standard deviation, fairly broad, and we show the control group, UIHO, with a higher average mean, 8, the A1C of an 8, compared to 6.9 for the APOD group, similar standard deviations, and a larger sample of 87 participants. Participants, how they were recruited, just briefly, from the neighborhood through postings. We put that little APOD talking circle poster up throughout the area. Newspaper notices were sent. Social media was used with announcements. And then adult diabetic persons, type 2, came forward, and pre-diabetic persons who had been told by a doctor that they had elevated blood sugars. And they were then invited to participate in our study. Potential participants were asked if they wanted to be part of a research study that required completing a brief survey, and the survey itself was based upon the PAM survey, and the study group then was comprised of these marketplace clinic and APOD members who were part of the program. Pre and post surveys were done, and we'll talk about that. So the implications really for global implementation are shown real quickly. There is potential, I think, for sharing this complementary network, certainly with other urban Indian persons throughout this area and throughout the United States, large urban areas, big cities. This community-based complementary network can provide resources, increased access to quality care, and an opportunity to help reduce diabetes health disparity throughout. There are global implications. There indeed may be socially responsible global entities capable of providing marketplace financial support and engagement. The startup funds needed needn't be great. During the 3 years study, this CVS and local health network Alina strategic partnership, they got together and contributed $50,000 per year for this project, which was nice, but as even better sometimes was the community-based diabetes complementation that they provided to help this cross-cultural and our indigenous people build a complementary cooperative that worked. We note that sustainable social change can come as these resources are matched with your resources, and steps are taken to share more equitably. In our case, in our United States, we note that the urban Indian population is actually 2/3, the majority of our nation's 4.1 million American Indian population. Who would have thought? Over the last 20 or 30 years, that now 2/3 and maybe even more, maybe 3/4 of all American Indians live in urban areas. We'll take some questions here at the end. And again, the references, make a note again that they're free. These article is free from Creative Commons. You can use it just fine. Just make reference and cite it properly with SAGE and open access. Our public. So thank you very much for your attention. And with that, we will conclude.